So we finished with the spinothalamic tract, right? Spinothalamic is the fast pain from the body. Spinothalamic fast pain that you can kind of say exactly where the pain is, and it travels pretty quickly up the system. We drew it out, right? We drew it out each step of the way. So now we are into the slow pain pathways, sometimes known as that divergent pain pathways, that are that slow aching type pain that comes on a second or two later, can last for hours and sometimes even days and weeks if it becomes chronic, years. But we'll talk about these. These are actually pretty easy to remember. We don't have to. I wouldn't memorize these individually, because they all use the exact same starting point and they ascend all together. The only thing that's different about them is where they terminate or end, and the name tells you where they stop, basically. And they also they run right with the spinothalamic tract all the way up the spinal cord, and they come in the same way as the spinothalamic tract. They run with it, all in that anterolateral system, that anterolateral area of the spinal cord. They're all running in that anterolateral system, the spinothalamic tract, and all these divergent pathways. It's just that the spinothalamic tract goes all the way to your cortex. These stop, well, one of them goes to the cortex area, but these just stop at different points before they ever get to your thalamus. So let's talk about those. And your book over the years has changed the name and terminology to use for these tracks, so I've had to adapt. They've changed it at least 4 different times, so it's a moving target on these. So right now, the 5th edition of the book calls this first track we're going to talk about the spinal emotional track. The 4th edition and 3rd edition, I think, call it the spinal limbic track. I like spinal limbic better because it tells me where it's going. It's going to the limbic system in the brain. So I'm okay with either one, but you should know. I think you should know kind of either one, spinal limbic and spinal emotional, for the exam. If I say spinal limbic, you should know that, and that's actually helpful for you to know where it goes. So let's talk about it. So you have the receptors, just like the spinothalamic tract, are the free nerve endings, right? The non-encapsulated free nerve endings that are sensitive to pain, acting as nociceptors. The modalities that this spinal limbic pathway transmits is slow aching pain that's hard to localize. You just say, oh, my arm really aches, or my wrist, or my hand, but you can't say it hurts right exactly there. So it's that aching, diffuse pain that you get a little bit after the initial quick pain. So the first order neurons in this pathway are the cell bodies, just like the spinothalamic, are in the DRG, the dorsal root ganglia. The peripheral nerve class, the axon class, in this case is a C fiber. C fibers are the slowest. Remember, they're like 2 meters per second. The spinothalamic was A delta, which are faster, than the C fibers. So this is using the slowest pain fibers, the unmyelinated or sparsely myelinated C fibers in the peripheral nerve. So that's what this is being transmitted on. Just like the spinothalamic, it enters the lateral division of the dorsal root. It may go into that little dorsal lateral tract of Lissauer. It may go up or down a few segments before it actually synapses in the dorsal horn with the second order neuron. The first synapse, just like the other thing, of the spinothalamic, is substantia gelatinosa, mainly lamina 2, but also lamina 1 and 5. So these are all the same as the spinothalamic. One thing different now, so there's a couple differences here. That it used the C fiber versus the A delta, and now it uses a slightly different neurotransmitter. Instead of glutamate, which is your most common excitatory neurotransmitter at those synapses in the central nervous system, it uses substance P, which is a neuromodulator, and it activates more G protein mediated channels, and which causes longer lasting responses and more diverse responses to those changes in the protein channel via substance P. So that you can see here that coming in, and that's where the substance P is released, right at that dorsal horn. The second order neurons, the cell bodies are in that substantia gelatinosa, lamina 1, 2, and 5. Just like the spinothalamic, it crosses that anterior white commissure and enters the spinothalamic tract or anterolateral area system of the spinal cord, all running together up through this area. Once it gets to the brainstem, it's called the spinal lemniscus. It's in part of the spinal lemniscus, just like the spinothalamic tract. The spinal, limbic, or emotional does go to the thalamus, because this is the one that goes to the cortex of these, but it goes to a little bit different region. It goes to the intralaminar nucleus of the thalamus. Instead of the VPL, it goes to the intralaminar nucleus. And I kind of think intralaminar because it's like the limbic system is kind of like the heart of your brain. That's the emotional part. And I think the same thing in the thalamus, that intralaminar, it's kind of in the middle, intralaminar, in between the laminar layers of it's kind of in the center of the thalamus, the kind of heart. So it's kind of, to me, it kind of has a correspondence to those locations, both in the cerebrum where it's going and in the thalamus. So that's intralaminar nucleus of the thalamus. And then it also goes through the posterior limb of the internal capsule, but then it goes to areas within your cingulate gyrus area, which is a big part of your limbic system. The cingulate gyrus, the fornix, the amygdala, those are all structures that are important for limbic system control. So that it terminates in multiple areas of the cortex, including areas related to emotion and personality. So they're also showing it, I think, going down to areas in the hippocampus and everything. So it goes out to some diffuse regions, but mainly those associated with our emotional, visceral responses to pain. Okay, driving some of our autonomic responses, the meaning of the pain and associated meaning and so forth. The next one is spinomesencephalic. Here again, the name tells you where it starts, spinal cord, and it tells you where it ends, mesencephalon. Remember the mesencephalon? Mes is the midbrain, and stays the midbrain throughout the development. So this is where, if you read something and they talk about there's a mesencephalic structure, that just means it's a midbrain structure. So you'll see some books, they'll say the mesencephalic structure, the substantia nigra is a mesencephalic structure, which just means it's a midbrain structure. So this means this track is going to terminate in the midbrain somewhere. Okay, so this actually carries pain information. So everything else is the same, the first order, second order neurons. And it doesn't have a third order neuron because it doesn't make it to the cerebral cortex. It stops in the midbrain. So it doesn't have that third order neuron, just two neurons in this. It carries pain and information to a couple areas in the midbrain, right here in the midbrain. It carries it to the superior colliculus, those little bumps back here. Remember the superior and inferior colliculi? And then also to the periaqueductal gray, which is a little bit of gray matter right around the cerebral aqueduct that runs down through the middle of the midbrain there. So it delivers that information to those two regions in the midbrain. The superior colliculus, if you remember, it's involved with reflexive movement of your eyes towards a visual stimulus. It's also involved with reflexive diversion of your eyes towards a painful stimulus. So you start to burn your hand, your eyes are going there because of that connection to the superior colliculus. Before it even hits your cerebrum, you're looking like, what do I need to do? Where is this pain coming from? Where do I need to move my limb from to get away from the pain? That's all happening even before you're fully consciously aware of that. So that's part of the thing for that. And then the periaqueductal gray, there's cells in there that have axons that descend down into your spinal cord and also to other regions of the brainstem to help activate your descending pain inhibition pathways. So that slow pain gets up there, and this is one of the mechanisms to say, all right, the pain happened. I moved my hand or whatever from the immediate stimulus through the spinothalamic, A delta. This also contributed because it helped move my hand, and I looked towards it. And then I get the slow aching pain that comes on, and then this says, okay, is the threat passed? Have I removed myself from the danger? Now I'm going to start down regulating that pain. I'm going to start turning that pain down if I don't need it anymore. If the stimulus is gone, it's going to cause this. And that activates some of the descending pathways, which we'll talk about here in a few minutes, the descending pain control systems. So that's spinal mesencephalic. Spinal reticular. So this spinal reticular, it tells you where it starts, spinal cord, and it terminates in the reticular formation. And the reticular formation is, they kind of have it, it's kind of got these little dots right here. So this whole region, kind of in the middle of your brainstem, this kind of just area here, this column here that runs throughout your brainstem, in the middle of the tegmentum. So this is the tectum right here, this back part. This whole middle section of your brainstem, all through here, this is kind of the basilar part of the pons. These are the pyramids down here. But this whole middle section is called the tegmentum. And within the tegmentum, there's this little area or column of cells that's called the reticular formation. Okay, and there's a bunch of stuff in the reticular formation. There's actually discrete nuclei and regions within the reticular formation that we'll talk about when we get to the brainstem and get into the details there. But I just want you to know that's all that is. It's just called the reticular formation. It's just this group of this area within the tegmentum. The middle of the brainstem on each side is this reticular formation, and that's where this pathway is terminating. So it runs right along with everything else, all the way up through the spinal cord, runs in the spinal lemniscus, but you'll notice it sends out little collaterals here to the reticular formation at various levels. So this pathway ends in the reticular formation in the medulla, in the pons, and in the midbrain, and stimulates areas of the reticular formation. Mainly, again, for playing a role in pain modulation and activating some of these descending pathways that go from our brainstem down to our spinal cord to say, hey, chill out a little bit, you know, let's get this pain under control. Okay, so that's what the spinal reticular tract does. And you see how it diverges? These are divergent pathways because they're going lots of different little regions to activate different processes and so forth. So, and again, these all use the C fiber to get in and substance P to that initial synapse between that first and second order neuron. Then we also have the trigeminothalamic tract. So this is our fast pain pathway for the head, okay, and face area. So fast pain. So this is equivalent of the spinothalamic tract, but for the head and face. Cell body for the first order neuron is in that trigeminal ganglion, right here, just outside the pons. This is what's a little bit interesting with this. It comes into the pons, and it actually descends down through the pons, through the medulla, and it makes its first synapse in the spinal nucleus of the trigeminal nerve. So there's a nucleus down here. And believe it or not, this spinal nucleus, it actually goes all the way down into the first few cervical segments. That's why it's called the spinal nucleus of cranial nerve number 5, because actually it goes down into the first 2 to 4 cervical. When you do a cross-section through that, you'll see the remnants of this spinal nucleus of cranial nerve number 5. It's a little bit of a mouthful, spinal nucleus of cranial nerve number 5. But your axons come in, they descend down to that nucleus where it starts in the medulla, and they even descend down farther and connect with that all the way down into that upper first few cervical segments to make their first synapse. So that's the first order neuron. The second order neuron, the cell bodies then are in that spinal nucleus of the trigeminal nerve. They cross in the lower medulla here. So they come down, they cross over in the lower medulla to cross over to the other side. And they cross in what's called, well, they cross over in the trigeminal, it's a trigeminal desiccation, but don't worry about that. But once they cross over, they ascend as the trigeminal lemniscus, kind of like the spinal lemniscus, the medial lemniscus. You're in the brainstem here. It's ascending as a lemniscus, okay? So it's called the trigeminal lemniscus. So the second order neuron ascends in the trigeminal lemniscus, which essentially ends up joining up with the medial lemniscus. And actually, when you're in the midbrain right up here, your medial lemniscus, trigeminal lemniscus, and spinal lemniscus are all right next to each other. They're all lined up there. So if you had a lesion right, and if you got a little stroke right there, you'd wipe out all your sensation to your whole face, body, everything. Everything is really compacted there. And they also stay that way up in the internal capsule area. They're all really close to each other. So once you get up into the midbrain and into the internal capsule, all the sensory pathways are right next to each other. So if you get a stroke in the right spot in the internal capsule, or a stroke in the right spot in the midbrain, or in between there, you can wipe out all your sensation on a whole half of your body, almost all modalities of sensation. Because once you get to the cortex, they start to spread out. So you might get a stroke that just involves the leg, and so you just have sensation problems in the leg, but your arm is fine. Or you might have a stroke out here where it just involves your face or your arm, but not the leg. But it's really, so if somebody has truly hemisensory loss in their entire half of their body, face, body, arms, and legs, you know that lesion has to be at the midbrain or above, or in the internal capsule. It's somewhere between the midbrain and the internal capsule and the thalamus. It can't be in the cortex, because the cortex, is very hard to have a cortical lesion that's that big that involves the whole side of your body where it's all impaired. So you don't have to quite know that clinical, but eventually you're going to have to know this stuff when we start asking you questions to make some of those judgment calls of like locating lesions. And the patient comes in and complains of certain symptoms, and you can say, it's roughly, probably has to be within this certain region based on that. The synapse then for the trigeminal lemniscus is in another region of the thalamus called the VPM, ventroposteromedial. The VPM, remember we said M, masseter, mastication, that's how I remember is from the face. So anything from the face is going to go to the VPM instead of the VPL or the interlaminar nuclei. It's going to go to the VPM. Then the third order neuron goes from the VPM up through the internal capsule to the postcentral gyrus. This is going to go over to where the facial region is here and give you localization of fast pain for your face. Trigeminal, thalamic. Then we do have a slow pain pathway for the face too, similar to those other three that we talked about, but they just kind of combine it all into one. Hey, how's it going, Des? And they call it the trigemino-reticulolimbic pathway. Again, that is definitely a mouthful. So the trigemino-reticulolimbic. So you see what it's telling you here? It starts at the trigeminal nerve. Some of it dumps out in the reticular formation in the brainstem, similar to the spinal reticular tract, and some of it goes up to your limbic system. So probably synapses, you don't have to know all the details, but probably synapses, some of those go to that interlaminar nuclei and then into the limbic system. Some stop in the reticular formation. Again, this is for the slow pain for the face and head. Okay? And then activate some of those descending pathways to control pain. So somatotopic organization of sensory information. We've mentioned the homunculus a few times. So if you take this, postcentral gyrus, and then you look at it in a coronal view, coronal section here, this is how your body is somatotopically laid out. And the size of these segments is corresponding to the relative size of real estate of surface area it takes up on your cerebral cortex. And that also tells you about the density of your receptors in those areas and the amount of information coming from those areas. And so you will see that, hand, face, tongue. Look how big tongue is just for one little body part. It's a pretty big representation. Even teeth. There's a reason why you don't like going to the dentist, because you have a lot of sensory information coming in your teeth and mouth area. And then even lips, how big lips are here. But then you look at things like knee, thigh, lower leg. Foot's pretty big, okay? Head and face are really pretty small, so you just don't have a lot of density of receptors in there, Just looking at locations too, when we start to talk about strokes and things like that, for example, the most common stroke is a middle cerebral artery stroke. And the middle cerebral artery's territory is kind of this territory right here. And so if somebody has a stroke in the middle cerebral artery, guess what gets more affected? Face, hand, arm. Very little leg. Now, the internal capsule, here's the thalamus right here. The internal capsule, some of these fibers, as they're swinging through to go to the leg, might get impacted by the middle cerebral artery stroke, but it's generally not nearly as bad as what's happening with the face and arm. Disproportionately, the arm and face are more affected in middle cerebral artery stroke than the leg. Okay. The anterior cerebral artery, which you don't have to know now, don't even worry about writing this down, supplies this region of the cerebrum. So if somebody has an anterior cerebral artery stroke, which is actually pretty rare, they would have much more leg involvement and very little hand and face involvement. So that's why, since most patients with strokes are middle cerebral artery strokes, we look like we're great because we got lots to work with. Because first of all, the leg, and when we get to the motor system, the leg and trunk work pretty automatically. So there's a lot of control that happens at the spinal cord level. So you can damage the cerebrum pretty good and still have some functioning of the legs through just spinal cord circuitry. But also they tend to be less affected with strokes, where the poor OT, you know, my wife's got to deal with somebody who has a flaccid arm, and how do you do that, make that better, and also how fine motor control and all that, especially when it's being so much more impacted. They have a much harder job, much harder task to do. So this is what you would look like if you were proportionate to your homunculus. If your body was actually proportionate to your homunculus, this is what you would look like. Big hands. This is just showing you some of the somatotopic arrangement. So remember the dorsal columns I told you about? So, you know, this right here is your fasciculus cuneatus. This is your fasciculus gracilis. But even within there, as the sensory information comes in from lower to higher, it gets layered on. So at the lowest level and most medial is sacral information. This would be proprioception coming from the sacrum. And then your lumbar area gets added on. Then your thoracic region gets added on more laterally, and your cervical region even more laterally. So there's a somatotopic arrangement not only in the cortex, but there's somatotopic arrangements of these pathways going up from even in the spinal cord, and as they ascend through your central nervous system. They tend to maintain some somatotopic arrangement in them. This right here is the anterolateral system, spinothalamic tract, and the way it tends to lay out here is your cervical stuff is actually the most medial, and then it goes thoracic, lumbar, sacral more laterally. Okay. When we get into the spinal cord, we'll talk about when you have a lesion in the central part of the spinal cord, how it might impact more here, you know, upper body and upper sensation for pain and temperature, and less lower body because, you know, this lumbar and sacral might be preserved here. Okay. The same thing is true for, this is actually your cortical spinal tract right here. This is a motor pathway. It also has some somatotopic arrangement. Cervical, thoracic, lumbar, moving medial to lateral is arranged this way for the motor tract, the main motor tract. So somebody who has, again, this more of a central kind of lesion in the spinal cord, they'll have more cervical and thoracic involvement, both motor and sensory, than they will lower body. So actually, it's a unique presentation. A central cord lesion causes somebody to have very weak upper extremities and poor sensation in their upper extremities, but their lower extremities working pretty well. So they're walking around and they have very little arm function, but pretty good leg function, because depending on the lesion, if it extends far enough laterally from that central region, the farther it extends out, the more you start to involve legs, but more central, it may just involve your arms. This is why it's important to know some of this detail a little bit so you can kind of understand this. So that is that lecture. Any questions about that one? And now we are ready just to go forward with the next one, which is going to be more of the clinical perspectives, which we just already started to introduce you to some clinical concepts. your book editions of just, they don't do a great job with some of this stuff. They just seem so random. Have you noticed that at all with some of these chapters? It just seems like they seem somewhat random in the information and how they provide it. So I try to follow what they do just so it's not totally different within pretty good reasons, so there's some match there, but I wouldn't maybe organize it the way that they've done all the time. But anyway, we'll go with it. It works. So we're going to start with sensory testing from the clinical side of what we do from a sensory testing standpoint, how we sensory test, what we're testing. So principles of sensory testing, these we've already mentioned in that lab we did in movement science, but ideally, when you do sensory testing requires somebody to be pretty cognitively intact and also be able to communicate to you accurately in order to get a good, accurate sensory test. There are tests you can do using nerve conduction velocities or somatosensory evoked potentials that doesn't require somebody to be intact cognitively, but the kind of testing we're going to do as a PT, it requires somebody who kind of is aware and can answer your questions clearly and knows what they're doing. So you want a quiet environment, you want the patient comfortable, you don't want them too cold, too hot, you know. You just want to make sure they're comfortable in their environment. You really want to explain and demonstrate what's going to happen. You're going to always do your sensory testing in a very systematic way. So you're doing it the same way every time with every patient, so you know when things deviate and you see abnormalities. So you get your technique down. In general, it's always good to start distal and work proximal with sensory testing. Okay, and also in general, it's always good you make sure you compare left and right. You know. And then also occasionally, if you're doing sensory testing that requires you applying stimuluses regularly, is sometimes vary your timing so the patient doesn't get accustomed to you applying that stimulus every second or whatever, and just they get into this habit of responding yes, yes, or you know, and so you want to like pause and vary the timing a little bit. So here's how we test, you know, different types of sensation. So discriminative or fine touch, localized touch, where they can tell you exactly where it is. There's a couple different ways. There's touch localization, where you touch them and you actually tell me where I touched you, and you just have them point to it or explain. But usually best just for them to point to it. Then when I'll show you tomorrow is, do you know what a Semmes-Weinstein monofilament is, or tactile monofilament for tactile thresholds? This is a little monofilament on a little stick, and you push that monofilament down on the skin, and you ask them if they can feel that when you press that. You deform the monofilament a little bit, and these monofilaments, you have a whole package of them, and they're all different thicknesses. They're like fishing wire, and they're thicker and thinner, and so their eyes are closed, and you're usually doing it on a discrete region, like usually just on their index finger or thumb, or oftentimes they use these. The most common reason they use these is for the bottom of the foot for diabetics, to see if they have a threshold of stimulus that they can detect. You have to have a certain level of sensation to know whether you're actually damaging your tissues or not. And there isn't actually in that packet, and we'll show you tomorrow, there's an orange. Like when you flip it, it's like a red or orange one. That's the sensory threshold you need. If you have worse than that, you don't have enough sensation that you can detect whether you're actually damaging your skin or not. So some clinics will just have that one, and they'll just test with that one. And if they pass it, then they figure, hey, you got enough sensation in your foot that we don't have to maybe worry about getting you custom insoles for your shoes or teaching you how to screen and look at your foot after every time you go for a walk. But if you get worse than that, then we need to talk about custom shoes and those kind of things. So those are Semmes-Weinstein monofilaments. They'll also do them, of course, on the hands, especially after doing hand surgery, or they're doing nerve grafting and stuff like that. They're trying to track how well that person's sensation is recovering. This is going to give you a much finer graded ability to see how their discrete ability to detect very just small changes in stimulus versus you just touching with a cotton ball or something like that. Does that make sense? So it actually allows you to score or grade. And there's actually, in the kit, it gives you the normal threshold stimulus for different regions of your hand and foot. And so you can compare your patient to what the normal thresholds are. Now, those change with age. You know, if you get somebody who's really older, that's going to be down from those, but these are just kind of averages. So that's the Semmes-Weinstein monofilaments. The other thing we use for discriminant touch is this two-point discrimination. I've explained to you these two little points, and we'll do that tomorrow in lab and see, can I detect whether the points are 1 or 2, you know. The closer you can detect the better that you are, and also probably the smaller your receptive fields are, okay? And then things like gravesthesia, stereognosis, and double simultaneous stim, we'll go through that tomorrow. Gravesthesia is where you write a letter on somebody's name or a number, and then their eyes are closed and you ask them to tell you what letter or number you wrote on their hand. That requires your body to put, put all the dots together, but then also requires another part of your brain to identify it as a letter or number. So it's not purely a sensory test. There's also some cortical sensory integration going on there to determine whether it's a letter or number and which one it is. Stereognosis is the one where you put different objects in the hand and identify what object you placed in their hand. And then double simultaneous stimulation will show you that, its ability to kind of discriminate whether you're being touched on one side or the other side or both sides at the same time. Okay. Then conscious proprioception, the ability to detect joint movement or joint position. We will show you that. This is where, did I show you where you wiggle the toe and you stop, up, down, finger, up, down, or bent or straight? That's the kind of thing we're talking about there. Or joint position, where I might just say, hey, I'm going to put your arm in a certain position, close your eyes, match it with the other arm. You're matching a static position. And so if I have a patient who has a stroke and I'm trying to determine if their weak arm, let's say they have an arm that's very flaccid, to see if it has good sensation or proprioception, but they can't move it, so I'll lift their weak arm, put it in a position, tell them to match it with their good arm, because they have to have sensation in this arm to go to the brain and then to tell them what position to put this one in. So, but I can just take and move it for them and hold it in a position and just ask them to match with the other good arm, and that will tell me about the sensation in that arm. But I can also do the, move the finger, and even if they're flaccid or can't move it, I move it for them, wiggle it, and tell them which position to stop. Or vibration, and which I use most often is tuning fork, which you guys learned is even more discrete and detects more subtle proprioceptive deficits than wiggling fingers and stuff like that, because there's just a lot of room for error. You start wiggling this finger, that gets transmitted all the way up to the shoulder, even to the shoulder girdle. So that person, you might be moving their finger and they only actually feel something happening in the shoulder. They have no sensation down here, but their shoulder joint is telling them that I can tell that's being pulled down or pushed up, or that can be that subtle. You got to be really careful when you do these to get a good, accurate reading on those. Then pain and temperature. Of course, we showed you sharp dull. You're not causing pain. That's the itch tickle pathway, which is that's the ability to sense something sharp. Like that's not really a pain. It's a tickle, but you're coming up to the threshold of pain, but it's the same pathway. Okay, and then hot cold. Of course, you can do that. Touching with a tuning fork, where I just say, is this cold? That's usually my quick way of doing it. So you don't have like two little things. I can warm up a little cup and have a cooler cup and test it the way it's supposed to be tested. And then deep pain and pressure. Typically, I don't test deep pain and pressure. Only if you do this if somebody's like in a comatose state or vegetative state. A doctor, I'm not usually doing this. They might come up and do the whole supraorbital pressure here, where there's a nerve that comes right out above your eye there, and just push really hard on the supraorbital area, and they're looking for drawing up or wincing or some response to the pain. If you don't have any response to the pain, that means your brain stem is pretty involved, and that's very, very bad. If you're comatose or in a vegetative state, that's bad too. Or a sternal rub, where they go in and they just rub your sternum really hard with their knuckles. That's a deep pain pressure on your bone, and that they're looking for just some response from the person to see if they withdraw from the pain at all. If they don't withdraw from the pain, that can be indication of kind of brain death and with involvement of the brain stem, because that's those primitive divergent pathways going to the reticular formation and so forth that also involve with these primitive withdrawal responses and things like that. So that's the Semmes-Weinstein monofilament here. It's got this little, monofilament you can see is kind of bending there. You apply the stimulus each time 3 times to the same spot. You just do it pretty slowly. If they can feel it 1 out of those 3 times, then you give them, they get credit for that. But a lot of times, if they only feel it 1 out of 3, I'm like, oh, let's do that again, just make sure, because they might have been like expecting, and sometimes you feel, I think I feel something, but I'm not sure, kind of thing. So you just got to make sure you're clear with that. If you're going to do a quick screen of your patients, the 2 that I think are best to do are vibration and sharp dull. You're testing with vibration. You're testing the medial lemniscal dorsal column system. And you're doing it in a way that's a little more fine graded. You can evaluate it and see just, how long does the stimulus last. You can time it if you want. And then sharp dull is the anterolateral system, right? Fast pain. So you're at least getting both major pathways of conscious. Because there's no way to, you can't really test unconscious proprioception other than watching them move. You're going to notice that they're ataxic if they have unconscious proprioceptive deficits. It's really a movement observation thing and looking for ataxia. But sharp, dull, and vibration are the two I start with, and just kind of see how they do. Start distal, work proximal, apply systematically, depending to dermatome, peripheral nerve distribution, or side to side, depending on suspected pathology. So if I have a patient who comes into me with diagnosis of a stroke, left-sided stroke, so we know the right side of the body, because all those sensory pathways that are that are conscious all cross, right? The spinocerebellar tracts don't, but all the conscious ones cross. So I'm going to want to compare left and right sides of the body throughout the whole leg and arm and up into the face even. Okay, so because depending on where that stroke, if I know they've got a big stroke in the internal capsule or up in the cortex, I want to get a feel for left and right, and so I'm going to be going back and forth, left and right, distal to proximal, in all limbs and face, okay, and test that, both sharp dull, light touch, sharp dull, and vibration. I'm going to do that. If it's somebody that comes in and has a C7 radiculopathy, they've got a big bulging disc at C7, and it's on the left side, I may not even test the right arm. I'm just going to be on the left side testing C7, C6, C6, C7, T1, C8, dermatomes within that limb, and may never even bother unless they say, yeah, I'm also numb over here or something, or you may get a little reference here, but it wouldn't necessarily be wrong when you're talking about efficiency. You got to do these things efficiently. I may just be testing within that limb, especially if it's a totally cognitively intact patient and they say, I'm numb right there. Okay, great. Let's test around it. Let's draw the lines where this numbness, and let's just see. And you've got a really big disc bulge impacting this would be C6 on your MRI. So, and then like peripheral neuropathies, like patients with diabetes, you're going to expect that they most likely are going to have equally distributed sensory loss in both feet and legs that is worse distal and gets better proximal. So in that case, I'm just going to be going back and forth, left and right, and just assessing where the cutoff point is. Where do they start to have normal sensation as I move up their legs or their arms? Okay. So with peripheral neuropathy, the way it typically works is, so it depends on the length of the nerve. The longer the nerve, the harder it is to support metabolically. And so with metabolic disease like diabetes, they have trouble supporting the longest nerves. And so the ones in your feet that are all like a meter that go up to here, they're going to die back first. Your arm nerves are pretty long, but not quite as long as your legs. So what happens is once you get up to the upper calf area or around the knee, that's when you tend to they start having the same problems at the fingertips. And then once you get up, mid-thigh and so forth, they start getting into the hands, and those start dying back because it's just a matter of the length of the nerve. Once you start matching that similar length, you're going to start having the same process happen in the hands and so forth. It actually eventually gets to the gut, so they have neuropathy in the gut, so they have motility problems, constipation, those kind of things. So neuropathy can not just affect your limbs, but internal processes as well. We don't do it, although some states, physical therapists do nerve studies, electrodiagnostic studies, and there's actually a certification and specialty thing you can do to get certification to do these types of tests. In Ohio, for the most part, physiatrists do most of the testing here. So usually in a neurology office, there's a physiatrist who's in their office with them, and the physiatrist does most of these nerve studies and testing with them. So it's really interesting. So we have you'll get to meet him, Dr. Began. He's a physiatrist, and he comes in and does a lecture on spasticity management in the clinical side of things. And so he does a lot of these electrodiagnostic studies. But in surgery, when the back surgeons are doing back surgery, they actually take these little little loops, and they tag the roots and the nerve roots that are coming off the spinal cord, and they tag them. And so as they're going in and cutting and doing work, if they impact either blood flow or something on the nerve will start to register that it's not conducting as well. and it's going on live, right? And so during some of his lectures, so he'll be up here, and on one screen he has his lecture. On the other screen is a remote thing that shows somebody in surgery remotely. He monitors this remotely, and he can tell during surgery if somebody's having a problem with their nerve. That he has to call or text the surgeon, hey, I'm noticing that this electrode is showing that you're, so I'm like, whoa, that's kind of, you're doing that while you're lecturing at the same time? That's pretty impressive. So I'm not sure I want to be that patient, but he's pretty good at it. So, but yeah, that's just very interesting how he does that remotely. Just sits at his office, or sits at home and monitors surgery from a remote location, and then just can tell him if something's going on with the nerve. So nerve conduction velocities is one thing. It's the only test large diameter myelinated axons. It's the one that when you stimulate the nerve, those are the ones that are going to fire preferentially. And it's hard to stimulate the smaller ones via external source like this. So it just really is testing large diameter myelinated nerves. It tests the speed of the nerve transmission in the periphery and through a specific location. So this is a very common one here. So this is the stimulator right here, okay? Let me change this to maybe a little bit of yellow. And this is the recording electrode right here. Here's the carpal tunnel, the median nerve, or a branch of the median nerve, and the median nerve running through here. So what you do is they'll go, and they'll induce a little shock, and this is, on the thumb there, that muscle will twitch. And when the shock is initiated, a timer starts, and then when that shock is felt at that recording electrode, because it's being passed through on the nerve, then the timer stops. And then you also know this distance. You measure that distance, so it gives you a velocity, how fast that signal traveled that little distance through the carpal tunnel, and see if the median nerve is being impacted at the carpal tunnel. And then it compares that to normative values, and they can tell you how impaired that nerve conduction is. So this is and you can do that. You can just mount the electrodes anywhere, and like across the elbow joint, down in the foot for tarsal tunnel syndrome, behind the popliteal area, whatever you want to measure. As long as you know the distance between the two electrodes, and then you hit the stimulator and he records it, and you can tell the velocity there. Okay. The other one is called somatosensory evoked potentials. This is kind of interesting. This is one you tend to see more in people with suspected central nervous system damage, like multiple sclerosis. It would be probably one of the more common ones they would do this with. What they do is they actually put electrodes. They stick them on your scalp near the postcentral gyrus. So they stick these electrodes on. So if I put them on the right postcentral gyrus, they can go down and they can stimulate my toe with an electrode. They stimulate it, and then it registers that stimulus up here on the surface of the scalp. You'll get a change in polarity up there. And at times, how long it takes to get from my toe all the way from the periphery into the spinal cord, up through the brainstem, and through the cerebrum to register there. And so people with multiple sclerosis, their peripheral nerves might be fine, but in the central nervous system, in the spinal cord, they might have lesions. In the brainstem, they might have lesions because they have demyelination. And they can then compare based on the distance there. They'll measure your height, and they'll say that time that it took to get there, is that within normal ranges, outside of normal ranges? Usually the person's saying they're complaining of numbness in that leg or something like that, or in this arm. You can do it in the arm, leg, and just time how long it takes to get to the cortex. So that's called a somatosensor, an SEP, evoked potential. This is probably a good time to take a little short break. Different lesions in the nervous system and how they can affect sensation. We've been mentioning this as we've gone along a little bit, but we're just going to tie it all together here. So peripheral nerve lesions. So peripheral nerve lesions can obviously affect sensation, because in your peripheral nerves, almost all your peripheral nerves contain sensory, motor, and autonomic. In those nerves, there's usually axons that are conveying sensory, motor, and autonomic information. So if you damage a peripheral nerve, there's a good chance you're going to cause some sensory loss, but also possibly some motor loss, possibly also some autonomic loss. But we're just talking about the sensation part right now, okay? So a radiculopathy is one that can cause sensory loss. That's a radiculopathy is impingement or damage or impairment of a single spinal nerve. Radiculopathy is a spinal nerve. C5, C6, C7, L4, L5. That's a radiculopathy. Okay. Diabetic neuropathy. We just mentioned that dying back because it's hard to keep the nerves healthy more distally. Idiopathic neuropathy. There's a certain percentage of people, they don't know why. It could be genetic predisposition. They just start to have neuropathy. Their nerves just die back and they don't have diabetes or anything like that. Any kind of nerve entrapment, such as a carpal tunnel syndrome, tarsal tunnel syndrome, any pressure on a peripheral nerve for a prolonged period of time can damage the myelin, the axon eventually, and impair transmission of sensory signals. Things like shingles, varicella zoster and herpes zoster, those are traveling down the peripheral nerves, the virus, and inflaming sensory nerves that causes extreme pain and inflames those sensory nerves. So it's not a loss of sensation, it's actually too much sensation, it's just painful sensation. And that's why when you have the shingles virus or the shingles, you'll see the blisters happen along the actual nerve trunk and the nerve as it goes through. A lot of times they're in the thoracic area and they'll travel along the rib right along or down the, you'll see the actual blisters in a dermatonal pattern because they're traveling down a nerve or a peripheral nerve pattern because they're traveling along, using the nerve to migrate that virus down that nerve there. So that's the periphery. Now we're up in the spinal cord, so spinal cord lesions. If you completely transect a spinal cord, cut it, or damage it so severely that nothing can get through that spinal cord, which is actually kind of rare. Most people that injure their spinal cord don't transect it. They bruise it, they get it, they twist it, they torque it, and you haven't disrupted all the communication going through that spinal cord. But if you do totally transect it, you will have complete loss of sensation 1 to 2 levels below where the actual lesion is. So if they have a C5, between C5 and C6, as you're testing their sensation, you'll go, this is where you're going to be doing more of a top-down, or bottom-up, and you're trying to determine where that cutoff is between a whole lower part of their body versus the whole upper part, where that level of lesion is. But as you go down, you might notice that they still have sensation even in a 1 to 2 levels below where their lesion is, because your dermatomes overlap quite a bit. And some people, so even like somebody's C5, C4 dermatome might extend all the way down into the C6, C7 dermatome. There might be some overlap there. So it's not like there's a discrete exact cutoff right at that. It does on some people, but it's like there's usually 1 to 2 levels below. You might still pick up some sporadic sensation because of the overlap of dermatomes. But everything below that is going to be gone. All modalities. If you've got a transected spinal cord, there's nothing coming up through that. So you've got loss of all pain, temp, proprioception, unconscious proprioception are not getting up to but you're also not moving your body. You're paralyzed as well. So then there's a unique situation. I've seen a couple cases. Called hemisection of the spinal cord, okay, which is also known as Brown-Secord syndrome. So hemisection of the spinal cord. In the hemisection of the spinal cord, you get a unique presentation. You get ipsilateral loss of proprioception. So when we're talking about ipsilateral, we're talking relative to the lesion, okay? So if the lesion is on the left side, you're going to get loss of proprioception on the left side below the level of the lesion. Below the level of the lesion. You're going to get, though, contralateral loss of pain and temperature below the level of the lesion. And I'll draw it out so you see all this happening. And then you'll get ipsilateral paralysis. We don't care about we're really focusing on the sensory part of this, but you'll also be paralyzed on the same side of the lesion. Okay? And I'll draw it out. And then in the next slide, posterior column lesions. So there are certain things. MS is one of them. Syphilis is another that will cause damage to just the posterior columns, your medial lemniscal posterior columns. So these people are walking around with impaired proprioception and have poor conscious proprioception, indiscriminate touch, but they have totally normal pain and temperature sensation because you've just destroyed only the back part of the spinal column or spinal cord. So let's draw out a Brown-Sequard syndrome here. So we're going to do a lesion. We're in mid-cervical right here. This is right, this is left. Okay? So somebody got a knife, somebody knifed somebody on the right side of their neck, but only got in and only damaged half the spinal cord. The right half of the spinal cord right here. Nice lesion here. So what we're going to have, we'll do pain and temperature in red, and then we'll do proprioception in a blue color. Okay, so let's do proprioception first. So if you recall, the medial lemniscal dorsal column system comes in to your spinal cord, goes up the spinal cord on the same side, right? It goes into the dorsal columns and goes up to the spinal cord the same side. It's going to get stopped by that lesion on its way up. It's going up to the brainstem before it crosses over, right? So this is coming from, you know, foot and arm and hand here, whatever. And so you've got loss of conscious proprioception, discriminative touch on the right side of your body below the level of the lesion. So if this is at C, 5, everything below C5, conscious proprioception, discriminative touch on that same side of the body, on the right side of the body, is going to be lost, right? Because on the left side, everything makes it past the lesion before it gets to the medulla and crosses over to the other side. So you've just blocked this one pathway that was trying to go up here and cross over the other side, but you blocked it on that side. So that's why it causes, this Brown-Sequard causes just this ipsilateral loss. Same side of the body, ipsilateral to the lesion. Then we have contralateral loss of pain and temperature, because if you recall, let's do our pain and temperature track in red. It comes in to your body, into your spinal cord. It goes maybe up or down a level or two, but not very far, and it crosses over immediately in the spinal cord. And it goes up in the anterolateral system pathway, and it's going to get stopped by that lesion if the whole half of the spinal cord is impacted there. And so now we got our leg out here that's been pain and temperature is now impaired in the contralateral side of the body. Everything below that level of the lesion, so here, hand is going to be impacted, forearm, to a point. If this is C6 or something like that, it's going to be, so everything below the level of lesion on the contralateral limb. Contralateral compared to where the lesion is. So this is respective to the lesion. So this is where you get this unique presentation of ipsilateral loss of proprioception, contralateral loss, because on this side, the pain and temperature stuff coming from the leg over here, it goes in, goes up or down a level or two, crosses over and misses the, misses the lesion. So it's okay on the same side as the lesion. We haven't shown you this, but the motor track, here's a motor track coming down. It crosses, I'm making it cross too early, sorry. Motor track comes down, crosses the medulla. It's going down here to move the right to move that right side of the body. It gets blocked by the lesion, and so the weakness is on the right side of the body. It's blocking the cortical spinal tract coming down on that side of the spinal cord. It's going to go move that side of the body, so it's causing ipsilateral loss of movement. So you have, you know, paralysis on the same side as the lesion, ipsilateral paralysis, because you've blocked the cortical spinal tract. Right now, we're most concerned about the sensory stuff, because that's what we're talking about mainly. I worked at a hospital, Columbia University, University Hospitals in Columbia, Missouri, which was a big level 1 trauma, kind of like a Miami Valley, but over in Columbia, Missouri, the capital of Missouri, but for a traveling assignment. And we treated all the prisoners there, the prisoners that had severe brain trauma or got in fights, or I've seen all kinds of fun stuff. People dropping 45-pound plates on people's faces and heads while they're doing a bench press, and then the bench comes down on their neck and breaks their neck and all that fun stuff. But this guy, particular guy, was shanked. You know, somebody still, you know, improvised shank or spoon that was sharpened. Somebody stabbed the guy, and it went in through just half of his spinal cord and gave him a Brown-Séquard syndrome. And we were working with him on the parallel bars, doing some activity, and the guard, you know, that was with him. So some of these guys were murderers and had 24/7 guards with them, and they had to be handcuffed at all times. So it really hurt your productivity, because there was a lot of time undoing the handcuff, then re-handcuffing them to the parallel bars, handcuffing them to their wheelchair. And you go down to the end of the parallel bars, they'd have to unlock the handcuff, switch sides, relock the handcuff on the parallel bars, go down the other side. And this gentleman, I don't know if he was a gentleman or not, but this patient, he had Brown-Séquard syndrome, and I tested these things, and he had classic Brown-Séquard syndrome. But the guard was like, he said, you got to watch out for these guys. They're good at faking everything, and I think he could just get up and run out of here. So we got to be really careful with this guy. And he was 6'4", 6'5", maybe 350, all muscle, and tatted all up, you know. And but I go, he'd have to be pretty damn good at faking. If he knows what Brown-Séquard syndrome is, and he's able to, like, know, you know, ipsilateral loss of proprioception and contralateral loss of pain and temperature, like, this guy's pretty smart dude. I mean, he must be doing some good reading while he's in his cell, because that'd be a hard one to fake. So I don't think he's faking. So that was kind of interesting. It was interesting, because my wife and I were working together at the time. We were doing traveling jobs, and we would co-treat together on some of these patients. And some of these guys, some of them were brain injuries too, so they didn't necessarily know what they were saying, but some of these guys were already impulsive. And so you can only imagine some of the things they might have said to my wife with me in presence while we're trying to be professional, working with, and some of the stuff that they would tell my wife they would like to do or what. And then it was like, whoo, give me serenity now. Don't not that I could probably do, well, some of these guys, if they were injured enough, I could have, like, kicked that external fixator on their leg or something like that. So that was interesting. My wife and I worked for a whole year together on the same floor, co-treating, and nobody even knew we were married. That's how good we were. That's how good we were at keeping our, like, professional boundaries. Pretty impressive. So possibly, so brainstem lesions is the next area. So spinal cord up to the brainstem. Now we're talking about brainstem lesions. Brainstem lesions get messy. I'm going to give you some very simple rules right now, but we'll get much more detail when we get to, like, there's common types of brain injury lesions, especially stroke types that we'll talk about that have characteristic, you know, involvement. But if we're talking just sensory right now with the brainstem, the key, if you have somebody that complains of loss of sensation on one side of their face, like left side of their face, and loss of sensation or problems of sensation on the right side of their body, the lesion has to be in the brainstem. That's the only place it can be, because there's only one place in your body where you can get that mixed sensory loss, and it's in the brainstem. As the trigeminal nerve and the cranial nerves are bringing sensation in, if you damage them on that side, but everything from the body is already crossed over when it gets to the brainstem, then that can cause this mixed sensory loss. Ipsilateral face, contralateral body, and we'll draw that out. So here's a lesion. Let's do a lesion, you know, kind of in this pons region here. Pons, upper medulla region. Here's a lesion right here. Here's our face, okay? Trigeminal nerve, right, is bringing in a lot of that facial information. But then we also have information coming from our larynx, pharynx, those kind of things, palate, soft palate. There's sensation in the back of our throat, those kind of things that are coming in from cranial nerves number 9, 10, 12, tongue. But anyway, they come in and they're trying to get into the trying to get into the brainstem, right? So in this case, this would actually be coming from this side of the face. This would be the face. That would be this is left over there. Sorry. Right. That's your. If it's looking at you guys, that's the left over here. If this person's looking at you. So anyway, so coming in from the left side, we'll say this is left in this case because it's looking at you. So it's coming in from the left side of the face. This is trigeminal nerve. It's coming in from the left side of the face here, and it's getting blocked by the lesion potentially as it's trying to come in. Remember, some of those fibers also go down, but don't worry about that. Just the trigeminal nerve trying to bring information in. It gets blocked coming in, causing left-sided loss here. But from the body, you know, we've got here's the dorsal column, medial lemniscal. It comes up in the medulla here and then crosses over. And this is the lesion from that same side of the body, from that left side of the body. But on the right side here, it comes in, goes up, crosses over, and boom, gets stopped in the brainstem on its way up. So we've blocked essentially information coming from the right side of the body for proprioception. And then for the pain and temperature, this is also the right pain and temperature, it comes in, it immediately crosses over and goes up and gets blocked too. Where on the other side, it makes it past the lesion. So here we have left facial loss of sensation, but right loss of sensation on the right side of the body. That's a mixed sensory loss. If your lesion is below, you're not going to have any facial losses of sensation. If your lesion is above the brainstem, if you're in the thalamus or the internal capsule, then likely you've damaged all of those on everything. If this has already come in here, so this is the other side of your face over here. I should draw. Here's this side of your face here. So this side comes in, trigeminal nerve comes in, it crosses over the other side, the trigeminal lemniscus, and then goes up here. And so everything's together when it gets up here to the thalamus region, internal capsule region. So if you damage it up here, if you have a lesion anywhere from the thalamus, internal capsule region where everything's close together, then it's this whole side of the body that's impacted. Does that make sense? So the only place you get this mix is if you just get this lesion really down more in that pons and medulla. Once you're in the midbrain, they're actually all close together too as well, as we mentioned. But it's really that lesion in that pontomedullary junction. And there actually happens to be a particular artery near there that is common to have a stroke that can cause this mixed facial and body loss of sensation where one half of the face and the opposite side of the body are impacted. That's really, right now, just know that if you see a question that says person has left-sided facial loss, right-sided body loss, here's the potential lesions, location lesions, cerebrum, spinal cord, brainstem, I won't get into like midbrain versus pons versus lower pons versus upper pons. It'll just be like, is it in the periphery? Is it the spinal cord? Is it the brainstem, the cerebrum? If you see that mixed pattern, just know it's going to be in the brainstem. That's all this is showing here. If you have a lesion somewhere in this region, blocking information coming in from the same side of the face, yet the opposite side of the body, everything's crossed over already, doesn't get blocked by that same lesion. That's all we're showing you there. Now, if your lesion is up in the cerebrum, now we're up in the cerebral area lesions. If you have a lesion just in the thalamus, okay, it can cause decreased or loss of sensation from the entire half of the body opposite, contralateral loss, right? Because the thalamus, by that time, all the sensory pathways have crossed over. All your facial body pathways have crossed over by the time they make it to that VPL or VPM, okay? So if you've got a lesion in the thalamus, a nice thalamic lesion, that's going to cause complete, could cause complete loss of sensation on the entire side of your body, face, body included, opposite of the lesion. Does that make sense? There is a unique thing called thalamic pain syndrome. Sometimes there's like, you get a unique small lesion in a certain region of the thalamus. Instead of causing loss of sensation and cause you to have hemi body pain, your whole half of your body is like on fire and in really severe pain. It tends to go away on its own, modulate over time, but some people will have this thalamic pain syndrome where they're like, just whole half of their body is in pain from a small lesion in the thalamus that actually doesn't wipe out the actual main pathways transmitting sensation, but it just causes this misinterpretation of all the sensory information coming to the thalamus to perceive it all as pain. If you just damage the cortex, that postcentral gyrus, that primary somatosensory cortex, you will get contralateral loss of discriminative touch, so conscious proprioception, discriminative touch, two-point discrimination, localization of touch, you know, so all that really finite, discrete, proprioceptive, you know, information coming from your body if you damage just the cortex, okay? You will also get some loss of fast pain. And I should probably put that in there too. You'll have loss of fast pain, will be dulled somewhat. So pinprick will be also impaired there. So you can put sharp dull sensation will be also lost contralaterally. And that would be in whatever region of the cortex is damaged. When you have, remember that strip goes all the way across your cortex, down to the medial surface of your cortex. So it's actually very rare to have that entire cortex all damaged equally. Most of the time we're talking a stroke or a tumor that's located and impacting a certain region of that cortex, that it's all going to be contralateral. So whatever that homunculus, whatever part of the homunculus it's damaging, you're going to have contralateral loss of sensation, okay? Not necessarily, so it's very common, in, like I said, in a middle cerebral artery stroke to have lots of loss of sensation in the arm and face, but not very much in the leg because the anterior cerebral artery is still supplying the leg part of it. But it's all contralateral. Contralateral face and arm will be very impacted by a middle cerebral artery stroke. And also, and the only thing, it's interesting, slow aching pain is pretty well preserved because you actually register pain, slow aching pain in the thalamus. The thalamus itself will give you that sensation without having to go to the cortex. What's also interesting is that vibration can be also preserved here because vibration is registered in the thalamus without necessarily having to make it to the cortex. And so that's where sometimes with just testing vibration, which I think gives you a more discrete level of ability of sense, but sometimes a person can feel vibration at the thalamic level and they still not be able to feel you move their toe and check that discriminative ability to tell what position their toe is. So occasionally, when I see that, if I suspect something like that, I might say, you know, I also want to not only do vibration, but I'm also going to actually go in and move that toe up and down or that finger and see if they can check that response. Especially if I know they have a thalamic lesion, you know, or I mean, not a thalamic lesion, because if their thalamic is preserved, then they might have this vibration sense. But they might have a hard time local. I say, can you feel the vibration? Yes. Which toe do I have it on? They may not be able to tell me which toe I have it on, but the vibration threshold stuff really tells me about their ability to sense where their foot is on the ground and proprioception a little better in most cases than wiggling a toe because there's so much room for air with it. So, if you damage the parietal association cortices, which are just behind the primary sensory strip, just behind the postcentral gyrus is this area, and I'll circle it on a picture here, called the association area. That's where you take that discrete information that you're getting at your postcentral gyrus, and you're making sense of it there and making determinations on, is it an object, is it something, giving it names, you know, that kind of thing. So there's another thing we can have there. So the couple things you can have if you have damage to that, you can have anosognosia, which is inattention or sensory inattention or neglect, where you can detect if you're only stimulating one side of the body, like sharp dull, they may test normally, but if you actually touch them on both sides of the body at the same time, they will ignore or forget that you're testing the one side because they're less attentive to it because they have damage to this postcentral or this parietal association cortices. Okay, so for example, if on the left side of my brain I have damage to just the parietal association cortices, my primary sensory strip is intact, that could affect my right side, right? But when I test their sensation, sharp dull looks good, proprioception looks good, all that kind of stuff, because the sensory strip's okay. But then if I say, now I'm going to test your left side here, and it all tests fine because this is all intact over here. Now if I say, I'm going to touch either your left leg or your right leg, I'm going to touch both at the same time. And I say, I just start touching left, right, or I touch both at the same time. What these people will do, if they just have damage to that parietal association cortices on one side, is I'll go left, right. They'll be able to feel individually when I'm touching their legs, but if I touch both at the same time, if the damage is up on my left side of my brain and I touch them both at the same time, they'll only say left when I do this one because they're just a little less aware. And when you touch both at the same time, they'll only think that you're touching their left side. That's sensory inattention. And that's called double simultaneous extinction. They have extinction to sensation on the one side when you touch their limbs at the same time. Because that one side that's damaged, even though it has individual discrete sensation when touched by itself, it can't pay attention to both stimuli at the same time when it happens at the same time. So that's called anosognosia, lack of awareness or inattention to your body. That's what lack of attention, agnosia to your body or body awareness in the space. So, but you have to do this very special double simultaneous thing to get that to elicit, or else, because if you test it individually, you won't notice it. You would have to kind of know, like, hey, I noticed on your MRI it's in this certain parietal region. I'm going to go ahead and test double simultaneous to see, because that just could get them into trouble in certain unique situations. Usually not a problem, but they may be just less attentive to that side in general. And so when they're trying to do things and manipulate objects with both hands or both legs or whatever, and they might have trouble doing things where it requires both limbs to be working together and the ability to sense what's going on, you know, so. Astereognosis is the lack of ability to tell what an object is, like three-dimensionality of it, and actually tell you what it is. So that's, you put that picture together, even though they have good sharp dull, good two-point discrimination, yet if you put a penny in their hand or a paper clip, it's round, I think, it's kind of like, but I can't tell you what it is, because you need to take that information and put it in that association cortices, which then also communicates with your Broca's and Wernicke's areas for speech to say, that is a penny, that is a, you know, so you don't have that ability of that damage. And then the agraphia, that's where, you know, you write on somebody's hand, you put their hand in a position like they're reading a piece of paper, so you actually put their hand in this position, so like they're looking at a page. They close their eyes, and then you write on their hand with capital letters or numbers, and ask them what letter or number you just wrote on their hand. And they have to actually take all those points and put them together in their head and identify it as a letter or a number, and that happens just behind the postcentral gyrus in that parietal association cortices. So here's our postcentral gyrus. This region right here is the parietal association cortex. So if they have damage in this region alone, then they could have perfectly normal sensation on all of our testing that we're doing until you get to those, you know, these types of things. All of this stuff could look totally good as far as sharp dull, light touch, temperature, all that stuff is fine. But it's actually pretty common to have some damage to both these areas, so it's usually not that clear cut, you know, where you have damage to not only the parietal association cortices but also the primary sensory cortices, so you can have problems with both of those. If you have damage to, I mean, if you have damage to just this and this is intact, if you've damaged this severely enough, you're not even getting good enough information to send to that area to make sense of it. So, but you're going to have poor sharp dull, poor pain and temperature, poor sensory tests. But if they check out really good on all those tests, but they suck at those astereognosis and the you know, agraphia, and they have those, then you know it's got to be just in that parietal association cortices that their actual primary sensory cortex is usually is pretty good. Okay. That's just the kind of brief little introduction to starting thinking about lesions and how they affect different things. We're going to, when we get into the regional systems, when we get into spinal cord, brainstem, cerebrum, we're going to do all that again, and we're going to just really hammer out with case studies. Like lesion is here in this region and what it's going to cause from a motor standpoint, sensory standpoint, and like autonomic, cognitive. So we're going to put it all together and do that. So. All right, we're going to talk about clinical perspectives on pain. Is there any dumber sport than that, than bull riding? Why, other than UFC fighting or whatever? I hope none of you guys ever watch that kind of stuff. That's just for barbarians, right? You guys. So I just can't watch that stuff. But so the reason I bring this bull riding up is so again at that University Hospital in Columbia, Missouri, it was a big mecca. There was a like area where they would have a lot of rodeos and stuff, and regional rodeos and national rodeos would come through town. And sure enough, in the neurotrauma unit, I'd get like 5 to 10 of these guys a year. It seemed like it was horrible. You know, and they'd fly them in on helicopters from around the surrounding region. But and I had one poor guy. One guy broke his neck one year and was a quad. And then the next year, his brother comes in with a severe, really bad head injury, you know, decerebrate rigidity, which we'll talk about. I mean, just really bad head injury. And I had to watch, you know, his mom, you know, talking to her from the first one and then seeing her again, just how devastated. She's got 2 kids. One's a quad, one's a, you know, and the one didn't learn from, I'm like, why did these, and they're all like, you know, 130 pounds soaking wet, you know, on these huge bowls. It's just like, what are you thinking? You know, eventually it's going to just get you, so. But anyway, I just can't imagine it. Painful sport. So let's talk about specific types of pain. So we're going to focus on pain now is what the focus is, which is obviously a sensory experience. So talking about pain from injured joints and muscles. So the actual initial trauma to an actual joint or muscle, and that's a pretty good example right there. Both A delta fibers and C fibers are going to be affected here. So you're going to get the fast pain, and then the slow pain is going to come via those peripheral fibers. The C fibers are very important for sensitizing. They're very sensitive to muscular ischemia. So when you actually have loss of blood supply to a region and you get ischemic, those C fibers get really sensitive and start dumping substance P, and you get this really achy, burny, just, have you had ischemic pain or anything like that before? Or, where you just, you know, and actually when you do the what's that cuff, you know, where they do the, what is it called, where they put the cuffs around and you pump the muscle, what? Blood flow restriction. That's causing ischemia briefly, you know, and that can cause your body to respond and actually, because of the ischemia, build things. But it can, if you left it on long enough, it can become really, really painful. Ischemia, like people have compartment syndrome. Have you heard of that? Compartment syndrome, where their fascia is too tight, and their blood, as their muscle pumps up in the fascia, it restricts the blood, and because the vessels are getting squeezed in that tight space, and it makes like this really aching, deep pain because of the C fiber sensitization of the ischemia. Also, the inflammation going on, just because of all the cells being ripped open, you're dumping all kinds of histamines and bradykinin and prostaglandins on these free nerve endings. It sensitizes them all and makes them really hyperactive. Like, don't touch it, don't get away from, that kind of stuff. Then we have referred pain, which is pain perceived coming from one site that's different from the actual site of origin. A radiculopathy is a form of referred pain. So like the pain, your patient comes in complaining of pain in their arm, but it's coming from their neck. That's a form of referred pain. Myofascial trigger points. Some people in their fascia, if you poke on it, and then they have pain in a different location. It's from a myofascial trigger point. And then referred pain from visceral structures, which you'll probably, I'm sure, talk about in medical diagnostics. Where here's a dermatonal region of your arm, and it's coming in to the spinal cord, to the dorsal root, and here's a free nerve ending pain receptor on your heart that's also coming in. Your heart is in that same region as kind of this thoracic region here, so the skin sensation and the heart sensation are both coming into the similar level of spinal cord, and there can sometimes be a little crosstalk between them. And so that'll make you feel the pain in your arm, even though it's coming from your heart, because it's harder for us to perceive where that location of pain is when it's coming from a deep visceral structure. So we may feel it in a region of our limb or something like that. And so you just see some of the other common skin areas that might be referred pain from visceral structures. Then we have what's called chronic nociceptive pain. This is chronic pain, but it's due to actual continued damage and destruction of tissue and stimulation of receptors in the periphery. So this is like, a tumor is growing and continuing to grow and press on free nerve endings and press more nerve endings as it pushes out, those kind of things. It's a continued stimulation of the actual peripheral nociceptors, okay? That is chronic nociceptive pain. It's nociceptive. It's stimulating nociceptors constantly, okay? Neuropathic pain is produced by a pathology in neural activity, but it's independent of actual stimulation of nociceptive nerve endings. So if somebody has neuropathic pain, it doesn't necessarily proportional or due to actual continued stimulation of the actual free nerve endings. So that you might have gotten rid of the actual, you've taken the tumor out, you've amputated the leg, but they still have pain. You've taken away the actual stimulation of the nociceptors, but you still might have pain. That's neuropathic pain. That's nerve-generated pain, not receptor-generated pain or tissue damage receptor. It's now the nerve that's continuing to cause the pain, and there's different ways that you can have neuropathic or different causes of neuropathic pain. So now we're going to focus on neuropathic pain a little bit. So it can happen in the periphery, okay? In the peripheral, you can have peripheral neuropathic pain, you can have central neuropathic pain, or you can have the pain matrix malfunction, which is involving both peripheral and central neurons that are involved with pain transmission, okay? So with peripheral, it usually involves some injury to the peripheral sensory nerve. There's some terms we use to describe some of this neuropathic pain. Sometimes they might consider it just a paresthesia, So paresthesia. So maybe you fell asleep, and you leaned on your arm weird, and you woke up, and you're having this tingly sensation that there's no nociceptive input. You took away the stimulus. You didn't even stimulate a free nerve ending. You just pushed on the nerve, and you got the nerve a little ischemic, or the myelin got damaged just a little bit, and it caused a disruption of the signal that's perceived as a little tingling, as a paresthesia. It's a non-pain, it's a painless but abnormal sensation. Okay. A dysesthesia is an unpleasant abnormal sensation. That's kind of like when you really lay on that thing for a long time and it starts to wake up and you go through that pain. We're like, oh man, this is like kind of almost painful. I'm not sure if this is pain or what it is, but this is really starting to like, is this going to stop soon? Because if I don't, I'm going to start to panic here a little bit. That's become more of a dysesthesia. And again, it's not due to stimulation of free nerve endings, but it's this unpleasant, abnormal sensation that might be perceived as pain, but it's not pain caused by stimulation of nociceptors. That could be a dysesthesia. Allodynia is pain from stimuli that's not normally painful. So people that have really hypersensitivity, like have a pain matrix malfunction, just the sheets brushing along their leg will cause pain. Even though you didn't even stimulate any, you didn't reach threshold for any of the free nerve endings. Remember, free nerve endings have a high threshold to stimulate them, to cause pain. But just pulling somebody's sheet up or lightly grabbing their arm, you know, and they're like panicking, that's a allodynia. That's pain from stimulation that is not normally painful. And that means there's something wrong with the signal transmission. You're perceiving non-noxious stimuli as noxious stimuli. There's hypersensitivity in some of your pathways that, that shouldn't normally be that active. Secondary hyperalgia is excessive pain from stimulation that should only be mildly painful. So that, yeah, if I push on your arm kind of hard or something like that, you're like, oh, that hurts a little bit. But if you've got some inflammation going on in the area and I push a little bit, you're going to pull away a lot sooner. That threshold's going to be reached sooner because those free nerve endings are sensitized, it's called secondary hyperalgia, where there's inflammation in the area. There's something going on where if you push on these free nerve endings now, they're already closer to that threshold in stimulus, and so it doesn't take very much. It normally would only be like a mildly painful, but now it's really painful. That's kind of what happens from neuropathic pain in the periphery. Centrally, neurons in the CNS are normally stimulated by periphery, become abnormally active. This is common with things like deafferentation and phantom limb pain. So deafferentation is where you like rip out the nerve roots from the dorsal roots, like a brachial plexus injury. I've seen this happen with motorcycle injuries where somebody falls, they hit a guardrail, the head goes this way, the shoulder gets depressed this way, and it actually avulses the nerve roots. You just rip the nerve roots. And sometimes it can be mainly the dorsal root, sometimes it's both the dorsal and ventral root, and rip it out of the spinal cord. And so normally what happens is in your dorsal root going in, you have pain, temperature, proprioception. You have a certain amount of stimulus from the environment, a background amount of information that's always coming in, that they tend to balance each other out. However, if you just rip nerve roots out, like dorsal nerve roots, now you have no sensory information coming from your body or from the environment. And the last sensation it felt was this ripping sensation and pulling out. And you can just turn on, and it'll feel like searing, burning pain with nothing to counteract it. So there's nothing to compete for that sensory areas in your brain, and all it does is feels pain, okay? And it's a very searing, burning nerve pain. Nerve pain has to be a burning, kind of searing, tearing kind of pain that is intractable, that doesn't wax or wane. It's just there all the time. No matter what, it hurts. They just say, kill me. Literally, I've had patients, please kill me. Because the opiates don't work. It's just a different type of pain that it's very tough. And you just hope it gets better through activity and experience in the body adapting to this new normal, whatever that is. Some people, it never goes away, and they have a certain amount of this all their life. And so that's the same thing with phantom limb pain. What happens is, so especially if somebody's had like a gangrenous foot they've had pain for a long time, so you develop these hypersensitive and strengthened pain pathways from this limb. Maybe they've been dealing with wounds in their feet for years and have had lots of pain. They amputate the limb, and so that's good. They got rid of the wounds and so forth, but you still have this strong pain pathway that's been developed over the years, but you also have gotten rid of all this other sensory input coming from that leg. And so what happens is your body tends to focus and just remember the pain pathway that was elicited through that time. Plus, you usually, after the amputation, you have some immediate pain due to actual damage to nociceptors. from the surgery and from the initial amputation, but they perceive the pain as coming from their foot still because there's still a memory trace on those nerves that you strengthened over those years to say, hey, this is a constant thing, and they actually lay down more receptors and more neurotransmitter. And so even if you activate down on the limb, they feel like it's coming from their foot. You could push on their end of their limb, but you don't even need to push on it. They can just have sensation of pain, especially when there's nothing else going on. There's nothing to distract them from that sensation. So actually what can help for Ly's patients is actually putting on their prosthetic and getting them to walk, and then your body will start to learn to feel your prosthetic. It'll interpret signals coming from the ground by the pressures on your leg, and it'll actually transfer that sensation in your mind down to your foot. So they can, like, patients can somewhat feel their prosthetic in a sense over time. And because now you're getting other proprioceptive input and those kind of things, it down-regulates the pain a little bit. Or you do the mirror training where you actually put them in front of a mirror, put the mirror between their, if it's their arm, if it's their leg, you sit them there, and a mirror is right between their legs, so they don't see their residual limb here. All they see is their good limb and a mirror image of it, which looks like their left leg. So if it's their right leg, they're seeing in the mirror. And then you have them do a series of exercises. You have them do ankle pumps, you have them do heel slides, and they just sit there and watch their right leg move. And the mind is tricked, because our visual systems are so strong and dominant, to think their left leg is moving without any pain. And then it down-regulates the pain responses that your left leg is feeling. And so you have to do this like 3 times a day for 15 minutes, where you just do a set of repetitive exercises where you watch your apparently amputated leg move, but it's your actual mirror image of your other leg. And you just have to do it enough to get enough repetition. And then once you've down-regulated it and maybe you've got your prosthetic, then you're usually pretty good. Sometimes you have to do it occasionally to kind of keep that process going. Pain matrix malfunction. So pain matrix malfunction is anywhere along the pain pathway: periphery, spinal cord, brainstem, cerebrum. And there's certain types of disorders that can involve all of that, and they're very complex. And actually one of the names is called complex regional pain syndrome. We used to call it, when I went to PT school, I don't even spell it out because you don't have to know it anymore. It was called reflex sympathetic dystrophy, RSD is what we learned it as, but they no longer call it that. They call it complex regional pain syndrome, CRPS, complex regional pain syndrome. Old terms for it used to be causalgia and Sudeck's atrophy or shoulder-hand syndrome. So really, this is what it's called now. But you may, if you hear any of these terms in a textbook or from a clinician, we're all talking about the same thing. If it's shoulder-hand syndrome, it just means it's happening in the shoulder and hand, because it can happen in the leg too. So what's interesting about this is there's central problems going on, but there's also peripheral problems going on. And it actually involves the autonomic nervous system too, where you get some abnormal overactivity of even the sympathetic nervous system gets overactive. And these people also get swelling and redness of their limb. And so there's some changes in the autonomic function of the nerve, in addition to this really hyperactive pain sensations that they get, and they can barely breathe on it and stuff. And it's usually finding a way to get them to move and interact and use the limb more normally in a very progressive, systematic way. So usually you don't want to rest the limb. There's that balance between, especially after surgery or something like that, where you rest the limb, but if you rest too long, you're setting yourself up for this, because then you get too protective of it. And there's certain personalities and genetic predispositions to getting this. And sometimes they'll come into your office and they're the total knee or the ACL patient, and you just look at their knee and they're freaking out and they're just, and you look at their leg and it looks just like it doesn't want to be moved, and like the skin looks a little shiny, it looks a little more red and irritated, but it's not infected, and you just watch their limb draw away from you when you try to get near it, and you're just like, and they're just this very high-strung, high-set person. But part of that could be the pain. It's just this mixture of things and you're just like, you are a case that you could easily get this syndrome, or you already have this syndrome, and it can be a real challenge to work with. And usually it's, you know, they even have, like, for shoulder hand syndrome, there's this device called the arm jack or something like that. And basically it's this little device, and you put your hand on top of it, and like you just basically load it like this, and you push down through it, and it's got a little scale, and it measures how much. You could do it with a scale, but this one has a little handle. You could, and you have the person just sit there and load through their arm progressively, and each day you have them load another couple ounces more on that arm, and you have them do hundreds of repetitions where they're just loading that limb, getting their system used to the input of sensory information coming through that limb in a very slow, progressive way. And then once they can load a certain amount, then you start having them do just simple, you know, put your hand up on the wall, do a little wall slides, turn away from your arm, turns your arm, you know, bring your arm up, bring your arm down, then eventually progress to resistive exercise. So it's this very progressive loading activity program. And you have to give them it super strict. You're going to do this many a day. You're going to do this many ounces of pressure, and we're going to just progress. And it's this systematic progression. And it's really also kind of like talking them into this stuff. So fibromyalgia is another considered a pain matrix malfunction. Involves both central and peripheral features that we still haven't identified all the. I'm not up to date on the latest on fibromyalgia literature, but. There's some mechanisms for producing neuropathic pain. The actual, you know, lead to some of these that cause these problems. So some of the, your book says 4. The previous version said 5, so I just said 4 or 5. Your book talks about these first 4. They don't talk about altered top-down modulation. So there's ectopic foci is one way that can cause this neuropathic pain. This is where you actually get demyelination of a peripheral nerve where that gets a little demyelinated. And that demyelination actually triggers some altered gene activity. And because of that, you actually, your neuron will then produce more receptors and protein channels, actually more protein channels in the demyelinated areas. So they actually become more hypersensitive to actually, instead of just having to stimulate the end of the neuron, you can stimulate the axon right in the middle. And it's more chance you can do that because as you start to get that little demyelination, where you get that those new little areas of membrane that are exposed, you'll put more protein channels in there. Okay. Now, if you get severe demyelination that's really bad, you actually reduce the ability of the nerve to kind of transmit information, so it might actually then transmit less. But there's an amount of demyelination that irritates the nerve, but doesn't decrease the transmission rate. Does that make sense? And that's called ectopic foci. These are areas, focal areas of demyelination along the axon and a peripheral nerve. They're ectopic foci, okay? And then you'll lay down more mechano and chemosensitive protein channels so that's just easier to stimulate the nerve, and anything rubbing on or anything nearby can cause that axon to spontaneously discharge. And if it's coming from a pain nociceptor, it's going to cause pain. Another is ephaptic transmission. Ephaptic transmission is where you get crosstalk between demyelinated areas. So this is very common like in carpal tunnel. So you've got this median nerve, you've got all these little axons near each other. They start getting rubbed on and pushed on and squished on from your carpal tunnel, pressing on them. And you might get some ectopic foci forming. You're demyelinating some of those nerves. And that's because they're near each other. Once you start to demyelinate them a little bit, they're less insulated. They get stimulated themselves just by the pressure there without even having to push on the nociceptors here. But one starts to get irritated, it can crosstalk with the ones nearby and stimulate those ones without ever having to stimulate a nociceptor. So that's called ephaptic transmission. So usually a combination of the things happens. You get both ectopic foci, and then there's other neurons nearby with their little areas of ectopic foci that can then now you get this crosstalk between them where you shouldn't have that crosstalk. They should be myelinated and insulated there. Over time, you can get central sensitization. So central sensitization is when you get just the neurons in that sequence that communicate from one region of your body that are transmitting pain, they get better at transmitting that pain. They like get more efficient. They start producing more neurotransmitter. They start laying down more receptor sites so that they actually get more effective in doing that, which if you're trying to really protect something long term, that's your body trying to protect it. But if the actual trauma is gone, we don't need that anymore. And by then it's too late, you know, kind of thing. And then you've got this central sensitization, so you get this spontaneous activity where even non-painful things stimulate that nice, really sensitized pathway of pain up to your brain, okay? And that's what we, as physical therapists of chronic pain, are trying to desensitize those centralized pathways through normal movement and activity experiences that try to normalize sensation coming up through there. Structural reorganization, these are all part of each other. Usually with central sensitization, you get some structural reorganization where you get, you know, A beta fibers that may now synapse with C fibers in the dorsal horn. So A betas are bringing in, you know, more proprioceptive type information. They may actually start causing painful. They start sprouting little collaterals and start causing stimulation of C fibers and give you that slow aching pain where they didn't before. You'll get changes in numbers of protein channels, and also the postsynaptic receptor fields will start getting more sensitive or expanding so you can absorb more neurotransmitter. So all those things are structural. Those are all a form of neuroplasticity. Then altered top-down modulation is where what we're going to talk about next is these descending pain control pathways are coming from your brainstem and your cerebrum. They no longer work as well. You're not doing a very good job of controlling your own pain. That's altered top-down modulation. Those can get impaired with certain disorders and certain genetic predispositions and personality types and those kind of things. Chronic pain syndrome is just when you have a syndrome, it's a chronic pain that lacks a direct relationship to specific tissue damage and mechanical stress. With chronic pain syndrome, you also see, if you measure like circulating endorphin levels, that people's ability to produce natural opiates are down. You can get these reverberating circuits where once you start the process, they keep stimulating themselves. Remember we talked about some of those axons sprout back to their own cell bodies, so you might get some of that going on. So once you stimulate it, it just keeps self-perpetuating. Because you're in pain, you're not sleeping. You get sleep disturbances. Also because you're not able to do the things you like, you get depressed. And then your serotonin levels change, and then you've got fatigue, and then you get this cascading vicious cycle going with this. Then you're no longer able to exercise, to produce your own natural opiates, you know, so it's just, you know, really a challenge. Evidence does not support a psychological etiology. So we used to always say, this is in your head, you know, it's a psychological weakness or something like that in the person. Now, believe me, there are people that have secondary gain issues, that pain is something that they benefit from, but most people don't choose to be in pain, and it's not a psychological thing. It is a physiologic problem in the brain and in the periphery, and usually a combination, but it's not usually a psychological kind of thing. Pain matrix, central sensitivity malfunction, we've already kind of mentioned these. Fibromyalgia fits into that category. This complex regional pain syndrome, AKA, we mentioned those. Disuse is the primary cause of this. If you have an injury and you just totally are protective and don't move it, you're setting yourself up for this if you have a propensity to it. Also, they've noticed that people that tend to have low serum norepinephrine levels are more prone to this. And I don't know if that's a cause or a consequence, you know, because usually they measure this after you've already had it. So is it they already have low norepinephrine levels and that makes them predisposed to this, or they get it after they get this thing? Then they get some impairment of sympathetic regulation of the limb, so the sympathetic nervous system kind of starts to go haywire on you as well. And then you actually eventually get cortical reorganization, where you get like expanded fields for that particular limb, so it becomes even more hypersensitive because you expand that cortical area for that limb, and it takes over other areas of your cortex. Migraines, we're not going to go into migraines, it's a very complex area, but migraines are malfunction of the trigeminal thalamocortical pathways. So the involvement of those, any of those pathways between your face, head, neck, is a dysfunction in those and integration in those. Your book also mentioned whiplash and chronic back pain fit under this, you know, pain matrix, central sensitivity malfunction, chronic pain syndromes that are common, you know. This is somebody with complex regional pain syndrome in the lower limb, so you can see the difference between those two limbs, and you can see the swelling, the shininess of the skin, the redness of the skin due to sympathetic tonal changes in the circulation. If you feel the limb, it's going to feel cold too. It's going to feel, yeah, it's really crazy. No way to fake that. You know, it's like, you're not faking that. Now let's talk. We're just going to try to keep pushing forward here. We should be done in the next few minutes here. How do we control pain ourselves? So there's different ways that we can control pain. They're called the anti-nociceptive systems. And it's through various mechanisms at different levels. Your book talks about 5 different levels that we can control pain, or opportunities we can modulate pain at different levels. Number 1 is in the periphery. Examples, when you use like non-narcotic NSAIDs, non-narcotic analgesics, Tylenol, aspirin, ibuprofen, they all do things like inhibit synthesis of prostaglandins to decrease inflammation, the sensitivity of the free nerve endings. Things like ice to decrease swelling and also just decrease the metabolic activity that's going on, and basically numb the free nerve endings temporarily so they're less sensitive by cooling them down enough that when you cool a tissue down, it doesn't. When you cool nerves down, they don't transmit information as easily. So that's including pain transmission. So it's temporary, but it can, make it feel better temporarily. But sometimes you want the metabolic process. There's all kinds of debate about whether we should even be icing people anymore, or the role of ice and those kind of things, and how often you should ice and stuff like that. So here's just showing some of the cascade of events that can occur. Here's a needle piercing somebody's skin, damages obviously some skin cells and things on its way in, some fat cells. They break open. They release some of their internal stores of prostaglandins, bradykinin, some potassium stores. All those things can cause increased sensitivity, and if this is a chemo receptive free nerve ending, the chemicals themselves can stimulate it, or they can just make them a little more hypersensitive. It goes down. This would be could be an A delta fiber. Could be in this case it's probably a C fiber, because what it's doing is releasing. These are some branches of the axon going back. This is going to a mast cell, and via substance P being released there causes the mast cell to release histamine, which also further increases inflammation and excitability of that free nerve ending. Some substance P is released in the blood vessel to make it dilate and get a little more leaky, so you get some swelling in there in that region, and then obviously some goes to cause pain to the dorsal horn region there. So this is now so ice can decrease some of this metabolic cascade. Ibuprofen, aspirin can decrease some of the prostaglandins and some of the cascade of events as well that are occurring in that region. Level 2 is what's happening at the dorsal horn. So we're working our way up into the nervous system of how to control pain. This is via inhibitory interneurons. One of the ways is through kind of what we call gating mechanism or a counter-irritant effect. The other is through release of endorphins, natural opiates at the dorsal horn. We have descending pathways, and also circulating our bloodstream. Eventually we can circulate some natural opiates that land at the dorsal horn and take over some of the receptors that moderate pain and decrease pain responses. And enkephalins, dynorphin, and beta endorphin are some of the main natural opiates that we produce. Here's the counter-irritant and gating kind of mechanism. So when you have information coming into the dorsal horn here is some tissue damage that's stimulating a C fiber, and this is an interneuron here that's going to cause pain, okay? But also coming into that same dorsal horn is you have mechanoreceptors, and you have conscious proprioceptive information coming in. Well, most of that goes up to your cortex to tell you about proprioceptive and what you're feeling. However, there's some collaterals that may go to the dorsal horn here and interact with an inhibitory interneuron, so that if these two signals arrive at a pretty similar time, you can actually gate this in effect by closing or opening the gate to that. If you can close the gate by stimulating this inhibiting interneuron, so you decrease the amount of transmission going through that. So you've all done this before, when you whack yourself or something and you grab it and you rub on it, you're doing that. You're just trying to stimulate a bunch of mechanoreceptors to bombard that dorsal horn to mask the pain a little bit and stimulate some inhibitory interneurons to downregulate that. So that's what you're doing when you rub on something and push on it and that kind of stuff, you know, is doing that. Now, if your limb's fractured and bleeding, there's a limit to some of that, but for certain types of pain, you tend to want to like push on it, rub on it, or something like that to distract it. Level 3 is the next level. This is called the fast neuronal descending system. So this happens really pretty quickly within a few seconds to minutes. It involves the raphe nuclei, which are in the rostroventral medial medulla. So the upper medulla, front part of the medulla, but more towards the middle. This is in the reticular formation. Remember I showed that reticular formation is in that tegmentum, that whole, this is one of the things that's in there is the raphe nuclei in that reticular formation. And so remember the spinal reticular tract, right? Spinal reticular tract going to the reticular formation. When that goes up to stimulate the reticular formation, one of the things it stimulates then is this raphe nuclei. Then the raphe spinal tracts, starting in the raphe nuclei, going down to the spinal cord, right? Raphe spinal. So it's going from the raphe. These are descend. This is a descending pathway that's going down, and it releases serotonin at the dorsal horn, which in turn, serotonin stimulates encalphin-producing inhibitory interneurons. The serotonin stimulates inhibitory interneurons, which produce encalphin, a natural opiate, to dump into the dorsal horn to decrease the sensitivity of the dorsal horn in that region. Remember, some of those also go to the midbrain, the spinal mesencephalic tract. The spinal mesencephalic that goes to the midbrain, it stimulates the periaqueductal gray and the superior colliculus. Well, when it stimulates the periaqueductal gray helps to stimulate the raphe nuclei and make them do even better job. So then the raphe nuclei will even do a better job of inhibiting. So the periaqueductal gray in the midbrain. And then we also have the locus coeruleus, which is in the pons, which is a nuclei or region, locus coeruleus, it's really a nuclei in the reticular formation of the pons. And it uses the cerebellospinal tract. So it starts in the locus coeruleus and goes down to the spinal cord. And it releases norepinephrine directly onto the primary afferent, which suppresses the release of substance P at that C fiber onto that dorsal horn. By squirting some norepinephrine in that region, it makes it so you squirt less substance P into that synaptic cleft. And that's how it downregulates pain. So it's, all these work at the same time, but they actually get there at little bit different times and build upon each other depending how long your pain is lasting and how severe your pain is. Don't have to know this picture. Just, I mean, know that conceptually. You don't have to know these tracks. The name tells you where it starts and where it ends. Just remember that for most of these sensory pathways, but also for these descending inhibitory pathways. Just the name tells you a lot right there. So, but they're all converging down here on the dorsal horn. So these guys are coming from the locus coeruleus. Here's the periaqueductal gray, which is going down to stimulate the raphe nuclei. The raphe nuclei send their signals down. They're all converging in that dorsal horn and acting in little different ways to downregulate the sensitivity of the dorsal horn. Level 4 is the hormonal system. This is a delayed effect. This comes on often several minutes to several hours later. It can last hours and potentially even days with this. So this involves the periventricular gray and the hypothalamus. The spino-emotional or spino-limbic pathway, one of its little branches, goes to that periventricular gray. We talked about the periaqueductal gray in the midbrain. The periventricular gray is some gray matter around the ventricle of the third ventricle up in your brain. It also involves the pituitary gland and the adrenal medulla. We release beta endorphins directly from the pituitary that get into our bloodstream, and then it takes a few minutes for that to circulate in our bloodstream and then to go to our spinal cord to eventually impact the pain transmission. So that might take several minutes, but it's going to stay in your bloodstream for several minutes to several hours. and keep going. The other one was more fast acting. It does its job, it does it pretty quickly, but then it stops working. This one takes a little bit longer, but it lasts a little bit longer to help. And this is the system that's activated more with like exercise, especially when you start exercising longer than 10, 15, 20 minutes, is you're getting this system to work better and be more optimized so that if you do experience pain, and people that do tend to do regular physical activity that's pretty intense, your body interprets discomfort differently psychologically, so you tend to have higher pain threshold to other types of pain as well, because your body's so used to experiencing discomfort, but interpreting it as a positive, until you, once you've, exercised for a while, until you have some discomfort, you don't feel like you got a good workout, and then you begin to realize, you associate that with improvements in performance and function and mood, and then it's this kind of self-fulfilling kind of positive feedback loop. You can help train these systems to be a little more tuned up and better, so when you do break that leg or you have a problem, you're more likely to be able to tolerate your responses to this and deal with pain better. You release of encalfin-like substance from the adrenal medulla. The adrenal medulla, which sits right on your kidney there, you can stimulate that, and that will produce some encalfins, which a like substance that's, again, like a natural opiate. These are delayed effects that can last for hours. Level 5, last level, is basically cortical, mind over matter. This is people like the, meditation, breathing, conscious control over your perception of pain. It's powerful. You can use it. You can train yourself to really do some powerful things with your mind over matter. For some people, it comes easier than others and takes some practice and so forth. But things like placebo effect. I had a boss that I worked for who got phenomenal results. He was the quackiest, kookiest guy, and never practiced in any evidence-based medicine, but he would literally come in, he'd come in, and every week it was some new thing he found on the internet or read about that he was going to do and cure every patient that walked into the office. But he believed he was going to cure them. The patients believed him, and he'd go in and he'd say, hold your hand up in this position, I'm going to touch your finger here, I'm going to touch your leg here, we're going to draw a line here. You're going to be better in 72 hours. You're going to be 80% better in 72 hours when you come back. Sure enough, most of the time they were 80% better in 72 hours because he believed it and he got the patients to believe it. So mind over matter, placebo. Use it. I mean, I would rather tell my patients that there's no magic I have. You can fix yourself through physical activity and through also using some cognitive things. I don't need to do some hocus pocus to you to make you believe that. I can teach you this. There's science behind this. Let's give you some skills to do this so you don't need me. And that's how I'd prefer to do it versus have somebody dependent on you. But so placebo and distractions. So getting ready to crack somebody's neck and they're really painful and stiff, and you're like, so how's the weather out there? And that's when you whack them when you're distracted from the pain. Or other distractions. You don't feel pain when you're doing some other kind of activity. It's when you're at night when you start to feel that pain because there's no other distractions. Excitement and fear can make your pain worse, so it can work both ways. If you're cold or you're fearful, or those things can make your pain worse. Anxiety, and you can modulate those things. You can be a very calming environment, influence. That I will tell you, if you're working with patients who have lots of pain, and if you, especially like I worked in the hospital that was like the second in the nation for total joints and total hips and total knees. So all I did all day long was 25 patients a day of moving everybody's leg for the first time. And the very first time you handle that limb, if they just trust you and you just do nothing that makes them feel untrustworthy, the next time you go in, you can do whatever you want. But that first time, you got to within reason. But if you don't get their trust that first time, that anxiety, that fear, you're just it's an uphill battle. So I handled their legs like it was just a fragile vase that was worth $1 million. And that very first time getting them out of bed, I was just so sweet and gentle, but I'm still looking at the watch like, we got to get up here. I got another patient to get to. But this first time, I want to make sure we do really good, because the next time, all right, let's go. And they would trust me, and they would move a little faster because they knew I probably wasn't going to hurt them. So those are things you can use to your advantage, and just think about. Okay, that's a lot of information. But the good news is there's no new information tomorrow. So you have from now all the way till next Tuesday, a whole week to absorb it and to interact with it and learn it and memorize it. No quiz tomorrow, so we'll start in lab. So meet in the main lab. We'll do some sensory stuff, then we'll come in, take a break, then we'll set up and do practice questions and then answer questions and try to make you feel like you know what to expect for next Tuesday.